This is for Jeannie Braniff. Chief complaint is stomach pain. The patient is a 38-year-old female, G7P3043. Past medical history significant for constipation and recurrent gonorrhea, status post-treatment. Presents with 2 days of diffuse abdominal pain. Patient states that she was in her usual state of health 2 days prior to admission when she developed sudden and onset diffuse abdominal pain. Pain is described as most severe in her right lower quadrant. It is non-radiating and has been worsening since that time. Currently, she describes the pain as 6 out of 10 in severity, constant, sharp, and stabbing in quality, and nothing seems to make it better or worse. She tried taking Tylenol and Percocet at home, however, this did not seem to give her any benefit. She states that there was no antecedent trauma, and there is no apparent relationship between the pain and oral intake. She states that she has not had pain like this before. Her pertinent gyne history is as follows. She estimates that her last menstrual period was approximately 6 weeks ago, states that she has a long-standing history of irregular menses. She is sexually active with several male partners with intermittent condom use and no other use of contraception. Her last STI screen was approximately 1 year ago. Pertinent review of systems. She states that she has been having fevers, chills, nausea, anorexia, and decreased oral intake. Pertinent negatives included no vomiting or bowel movements times 2 days. This is since the time that the pain has begun. She states that she has no dysuria, no urinary frequency or urgency, no hematuria, flank pain, or sick contacts, no vaginal discharge or painful intercourse. Her past medical history is as follows. She has heavy menses, never formally evaluated. Her menses last for 5 days, and she changes her pads 3 to 4 times per day when she has her menses. She has constipation, complicated by occasional hemorrhoidal bleeding, but this has been improving with Miralax, and she's had gonorrhea multiple times. Her last episode was 1 year ago. Her gyne history, as mentioned above, she's G7P3043. All births were spontaneous vaginal deliveries. Her past surgical history was 3 surgical abortions. Last was 2 years ago. She has no known drug allergies. However, she does have an intolerance to codeine where she complains of headaches. Current medications include Tylenol at PRN and Percocet PRN. For her social history, she cleans houses for a living. She lives with her boyfriend and 3 children. She feels safe in her relationship. She is an active smoker, smoking 2 packs a day for the past 24 years. She drinks 40 ounces of beer 2 to 3 times a week, has no IV drug use or recreational drug use. Sexual history is as per the HPI. She's had no recent travel. She's on medical assistance. She does not have a PCP and gets medical care in the ED and urgent care centers. She has no family history that is known as she is adopted. For her full review of systems, the only other significant positive is occasional bright red blood on the toilet paper when wiping associated with straining, which is unchanged in a chronic issue for her. Physical exam. Vital signs. Her temperature is 99 degrees, her heart rate is 108, blood pressure is 110/82, respiratory rate 22, O2 sat 97% on room air. She is a young female in mild distress due to pain, dry mucous membranes. Her lungs are clear to auscultation bilaterally. She is tachycardic with no murmurs, rubs, or gallops with S1, S2. Her abdomen, soft, non-distended, normal active bowel sounds, no hepatosplenomegaly, severe tenderness in right lower quadrant with voluntary guarding and mild rebound tenderness. She has a negative Murphy sign. She has no CVA tenderness. On rectal exam, she had right-sided tenderness with small external hemorrhoids or no blood or masses. For a pelvic exam, she had a normal external GU in vaginal walls. She had a friable cervix with moderate cervical motion tenderness, right adnexal tenderness, and no left adnexal tenderness. She had no lymphadenopathy. She had no clubbing cyanosis or edema, and she was awake alert oriented ×3 lab findings. For her CBC, her white count was 15.4, her hemoglobin 14.8, and her platelets 457. For her BMP, her sodium is 132, her potassium 3.8, chloride 106, bicarb 22, BUN 42, creatinine 1.3, glucose 97. For electrolytes, her calcium is 9.3, her mag 1.6, and her phos 4.2. For her liver function panel, her AST is 13, ALT 14, alk-phos 80, and T-Billy 0.9. A UA dipstick was done, which showed a specific gravity of 1.003, a pH of 6, positive leukesterase, positive nitrates, negative blood, negative glucose, and negative bilirubin. She had a positive beta HCG in her urine, and her serum was 3,940. Imaging. A transvaginal ultrasound was done. No intrauterine products were visualized. There was complex inhomogeneous extra-ovarian right-sided adnexal mass. No free fluid seen in the pelvic cul-de-sac. Assessment and plan. Assessment. Patient is a 38-year-old G7P3 with history of constipation and gonorrhea who presents with 2 days of abdominal pain, subjective fevers, and amenorrhea, found to have right lower quadrant tenderness and cervicitis on exam, and positive beta HCG with no intrauterine products visualized on transvaginal ultrasound. Problem number 1, right lower quadrant abdominal pain. The differential as it stands now is broad and includes multiple organ systems including GYN, GI, and GU. The must rule out diagnoses include an unruptured ectopic pregnancy and PID, more so than appendicitis, more so than pyelonephritis, more so than ovarian torsion. Ectopic pregnancy is supported by positive beta HCG, amenorrhea, prior history of STI, and risk of PID leading to abnormal GYN anatomy. Her pelvic inflammatory disease is another potential etiology, supported by cervicitis and adnexal tenderness on exam, along with multiple identified risk factors, for example, intermittent condom use, multiple sexual partners, prior history of gonorrhea, and her subjective fever. Appendicitis is supported by her right lower quadrant pain and constitutional symptoms. However, it doesn't explain the cervicitis seen on pelvic exam, and this has not been ruled out on imaging thus far. Pyelonephritis. Location of the pain isn't classic for pyelonephritis, and the patient denies any symptoms consistent with a UTI, would expect CVA tenderness on exam, and doesn't explain findings on pelvic exam. Torsion is supported by right adnexal tenderness, but constitutional symptoms and cervicitis on exam are not consistent with this diagnosis. Furthermore, the transvaginal ultrasound would have showed torsion, and this was not seen. Other etiologies that are unlikely to be the cause of patient's symptoms are endometriosis, diverticulitis, large bowel obstruction, and nephrolithiasis. Plan. Check cervical gonorrhea, chlamydia, nucleic acid testing. If positive, we'll begin antibiotic treatment. Screen for other STIs, such as obtaining an RPR, HIV, and antibodies. Given tachycardia and dry mucous membranes, we'll give 1 to 2 liters of LR, reevaluate heart rate, and give more fluids as needed. We will consult GYN. Patient is currently not showing signs of a ruptured ectopic pregnancy. However, management would be medical abortive, such as methotrexate, versus surgical. We will defer to GYN regarding best possible management. Obtain right lower quadrant ultrasound for evaluation of appendicitis, as this is a must rule out diagnosis. We will avoid a CT scan in the setting of having a positive pregnancy test, even though there are no intrauterine products noted. Start pain control. Ketorolac likely most helpful. However, in the setting of possible surgery and a positive pregnancy test, we'll avoid NSAIDs. We'll use opiates and aggressively manage constipation. Morphine 4 milligrams IV, Q4 PRN, severe pain. We will also treat her nausea with Zofran 4 milligrams IV, Q4 PRN. However, we'll need to obtain an EKG to check QTC, as Zofran is a known QTC prolonger. Problem number 2, constipation. Patient has a long-standing history of constipation, has hemorrhoids as a result with some bright red blood per rectum, will need standing management. We'll use Miralax 1 capsule BID and Senna 17.2 milligrams BID. Next problem, alcohol use. Patient has no known history of withdrawal. We're going to monitor closely in-house. No need for SIBO monitoring at this time. We'll need to determine when last drink was, and then counsel the patient on cessation. Next problem, tobacco abuse. We will continue offering counseling and offer nicotine replacement in-house. We will also consult the smoking cessation team. Hypomagnesemia. Patient came in with a low magnesium level. We will be giving 4 milligrams mag sulfate IV. Hyponatremia. This is likely due to limited PO intake. Patient is showing signs of hypovolemic hyponatremia. We'll give IV fluids and then reassess tomorrow with a repeat BMP. Can consider FeNO labs if not improving at that time. High-risk sexual intercourse. We will counsel the patient on safe sex practices and follow up with primary care for close follow-up of STI screening in the future. Global. Patient is NPO for now until GYN evaluation. We will give IV fluids PRN, and her code is full. Dispo. She'll be admitted to medicine for inpatient management. Will likely be able to be discharged home at the time of discharge. Thank you. That ends my presentation.